Welcome to Final BDS MEDC. Bell's palsy is one of the important 5-marker questions in the subject of oral surgery for your final year exams. Bell's palsy is a type of facial paralysis resulting from dysfunction of the facial nerve, that is the 7th cranial nerve. This leads to an inability to control facial muscles on the affected side, causing significant functional and aesthetic complications. Starting with the etiology, the causes of Bell's palsy can be classified into three major groups. That is the intracranial or central cause, which includes vascular abnormalities, CNS degenerative diseases, tumors of the intracranial cavity, trauma to the brain, congenital abnormalities, and agenesis. Intratemporal causes include bacterial and viral infections, cholesteatoma, trauma including blunt temporal bone trauma, longitudinal and horizontal fractures, and gunshot wounds, tumors invading the middle ear, mastoid and facial nerve, and iatrogenic causes. Extracranial causes include malignant tumors of the parotid gland, trauma such as lacerations and gunshot wounds, iatrogenic causes, primary tumors of the facial nerve, and malignant tumors of the ascending ramus of the mandible, pterygoid region, and skin. Next is the pathogenesis. Bell's palsy can occur due to nerve damage due to inflammation, compression, or transection of the facial nerve, which disrupts the transmission of motor signals. Or there may be Wallerian degeneration, that is degeneration of the nerve distal to the site of the injury. And in some cases, it may be due to axonal regeneration. That is when the nerve attempts to repair itself, which can lead to synkinesis or unintended movements. Next are the clinical features. There is motor dysfunction. In cases of upper motor neuron lesion, there is contralateral lower facial weakness with forehead sparing, and in cases of lower motor neuron lesion, there is ipsilateral weakness of the entire face, including forehead. There is also sensory dysfunction, that is hyperacusis, which means increased sensitivity to sound, loss of taste on the anterior two-thirds of the tongue when chorda tympani is involved, and autonomic dysfunction, which is decreased lacrimation and salivation. Symptoms and complications. There is weakness or flaccidity of facial muscles leading to paresis or paralysis. Difficulty in drinking fluids and mastication of food due to loss of motor control of the lips and cheeks. There is drooping of eyelid, drooling of saliva, pain, infection, and reduced visual acuity due to corneal ulceration. And there is asymmetry in facial expression causing social embarrassment and disturbance in social life. Coming to the House-Brackmann classification, grade 1 is normal, that is normal facial function in all areas. Grade 2 indicates mild dysfunction, that is slight weakness noticeable on close inspection, complete eye closure with minimal effort. Grade 3 indicates moderate dysfunction, in which there is obvious but not disfiguring weakness and complete eye closure is possible with effort. Grade 4 indicates moderately severe dysfunction, in which there is obvious disfiguring weakness and incomplete eye closure. Grade 5 indicates severe dysfunction, in which there is barely perceptible motion and asymmetry at rest. And grade 6 indicates total paralysis, in which there is no movement and asymmetry at rest. Diagnostic aids include the clinical examination, that is assessing the symmetry and movements of facial muscles. Then electrophysiological tests include the nerve conduction studies and electromyography, and imaging like MRI and CT scans to identify the cause of nerve compression or damage. Management includes reassurance and explanation. Reassure the patient that the condition often resolves without residual effects. Explain the condition and expected course of recovery. Use an eye patch to prevent corneal ulceration. Apply topical ointment and close the eye with a cotton pad. Avoid contact lenses. Instruct the patient to avoid wearing contact lenses until the paralysis resolves. And last one is documentation. Record the incidents on the patient's chart for future reference. Medical therapy includes steroids like prednisolone to reduce inflammation, antiviral drugs such as acyclovir for herpetic infections, facial exercises to maintain muscle tone and prevent contractures. Surgical options include decompression surgery for nerve entrapment, nerve grafting in cases of nerve transaction, and static procedures like temporalis muscle transfer or facial udder sling for long-term paralysis. Now let us look at the protocol for treatment. First step is reassurance, that is, reassure the patient and provide symptomatic relief. Use an eye patch and topical ointment to protect the cornea. Then next step is surgical repair. Open injury should be repaired surgically as soon as possible. Immediate primary repair or delayed primary repair, that is within 12 months, is often considered the limit for successful repair. Then neurography procedures, that is direct end-to-end approximation and suturing for lacerations and benign conditions. Autogenous nerve grafting using nerves such as the hypoglossal nerve or the sural nerve if there is a gap between the proximal and distal nerve ends. Complications include corneal ulceration due to inability to close the eye, synkinesis, that is involuntary movements during voluntary facial expressions, and facial contractures, that is permanent tightening of facial muscles. That's it. Thank you for watching. If you appreciate this video, do hit the like button, share it with your friends, and please subscribe to my YouTube channel. Stay tuned for more such videos.